The following recorded program is part of the Mount Sinai Medical Center Lecture Series, offered by Mount Sinai Medical Center in cooperation with the City of Sunny Isles Beach.
Thank you. Good morning, everyone. Good morning, good morning. Happy New Year. Pleasure to see everybody again. It's been a while since I've been here, so I'm very happy to see all of these familiar faces from my last lecture. Several reasons why we're here. One of the main reasons is to let you know that Mount Sinai is present and we're here in the community, and our goal is to offer education to everyone. Please take what you can from this lecture. I'm a very interactive speaker. I like to ask questions. I like to engage our audience. Feel free to interrupt and ask questions at the same time. It's a conversation. It's a dialogue. That's the only way we learn. It's not just me giving you information. You guys share your information with me, and I learn at the same time too. So it's very important for you to know that I'm equally paying as much attention to you as you are to me, and I want to give you my full undivided effort. If you have any questions during the lecture, please feel free to stop me. Please feel free for clarification if you need me to go back, if I need to speak louder, whatever we need to do so that everyone gets the most that they can out of this lecture. Our goal is twofold. First is to educate. Always, always, always continually to educating our patients and our community. Education is key because if you don't know what you're diagnosed with, what the side effects of those diagnoses are, and what the impact it will have on your life, you're not going to know the questions to ask the physician. You're going to feel unprepared. And you're going to walk out with a new diagnosis from the ER and not know what to do with it or how to improve your health and your lifestyle. Okay? So education is key, number one. Number two, I want you to feel that this is a mutual relationship. I want you to feel that you are involved in your health, that you know what's going on, and that you know where to go once you leave the ER. I don't want you to feel lost once you leave the ER. If that is how you feel, then I didn't do my job. I didn't explain to you your diagnosis. I didn't explain to you the side effects, the medication I'm prescribing to you, what to potentially expect afterward, and long-term, who to follow up with. Second goal out of this lecture is to let you know that Mount Sinai is present. We are located here in Aventura. It's the freestanding emergency department. We have our main campus that's located in South Beach, Florida. We're down here at 2845 Aventura Boulevard, right across from the mall. So we're on 199th near that Chili's, okay, in that shopping plaza. When you pull up, it looks like you're pulling up to an office building. Because remember, the ER is on the very first floor of that building, and then above us, we have the physician offices. So they run on more of a 9-to-5 schedule. We are 24 hours, 7 days a week, holidays, there's no exception, okay? We function as a full emergency department. We have CAT scan, we have X-ray imaging, we have ultrasound. The only thing I do not have in this emergency department is an MRI machine, and I cannot admit you at this location. Because we are a sister property with the South Beach location, all of our patients that require to be admitted to the hospital for additional antibiotics or surgery or treatment or specialties, they get transferred by ambulance from our location directly to their room at the main campus, okay? Just so you understand how we function, that we're completely available. We see pediatric patients, we see elderly patients, and everyone in between, okay? Yes, they do. Fire Rescue brings people to our facility, and you can request to come to our facility as well. So if you're at home and you call for Fire Rescue, say, hey, I want to go to Mount Sinai Aventura, and they have to bring you there, okay? You always have a preference. They can't just drop you anywhere. The only thing I will say is we don't do trauma. So if this is a traumatic injury that requires immediate neurosurgery or something to that effect, they'll bring you to the closest trauma facility and the hospital that best suits what's going on for you at that time. But if this is more of, I feel short of breath, I have chest pain, my physicians are in the Mount Sinai location, I want to be brought to the freestanding Mount Sinai Emergency Department in Aventura, that's where you tell them you want to go, and that's where they will bring you. All right. I didn't tell you who I am. So my name is Safiya Lyn-Lassiter. I have been with Mount Sinai for over 2.5 years now, and I've actually been practicing down here in Florida for 4 years, and prior to that, 4 years in New Jersey. Originally from New York native, so this is very familiar weather. Not so pleasant, but familiar nonetheless. And it's been awesome. I moved down here, number one, for lifestyle and weather. So no looking back. I have a 8-year-old daughter, and she is in school in Davie. So I practice at the freestanding emergency department, and I mainly do nights. So if you have any questions, I'm there mainly overnights, but I can be reached during the day. I have my card here. I'm always available by email and text as well, too. Okay? My specialty is adult emergency medicine. That's what I'm certified in. And yes, I see pediatrics as well, too. Okay? So our topic today is opioids. How is this epidemic important, and how does it affect you? Let's start by defining a couple terms and getting familiar with what we're going to discuss. Does anyone understand what opiates are, why they're important, why are we even having this topic today? Why is this an issue and a crisis in our country right now? Tell me.
People are becoming addicted to this stuff, and many of them die because
Absolutely. Addiction leads to death. That is our whole purpose of our discussion. If people weren't dying, if there wasn't that response of death, then we wouldn't even be talking about this. Okay? If the people were just taking pills and getting better, then that would be a highlight. People are taking pills, becoming addicted, and eventually dying. So our goal is to make sure that we as prescribers are doing the right thing for our patients, and we are the people who are dispensing this medication to you. So this is not just educating you, but education for us, so that we know how many pills to give this patient. Are they at high risk for addiction? Is this the right medication for the patient? Should I think of an alternative that has less additive properties? Those are all questions that need to go through our mind as we go through the discussion of what should we prescribe for pain once you leave here? How can we make sure we're addressing this issue for you? Okay? So it's an epidemic. And not only that, our tax money is being allocated to this epidemic. So you want to know where your money is going. Every day, every year, you're paying taxes. And you want to know what is in the budget for 2018. What are we expecting? Where is this money going to go? And what is it going to be used for? So that's a very important discussion politically as well. I'm not doing as much of the political talk as I am focusing on the medicine of this, but that is also another aspect of the conversation as well. Some important definitions are drug misuse, drug abuse, and drug diversion. So when we give you a prescription, the goal is to take it as prescribed. I'm giving you a total of 7 pills. Take 1 pill every day in the morning, right? Drug misuse is when you take medication in a manner other than how we prescribe it for you. The person is not likely looking to, quote unquote, get high from this use, but they might either not understand the directions, they might need the directions to be translated in their native language. I have a lot of Russian-speaking and Spanish-speaking patients in the emergency department, and most of the time the directions are in English. So they're going to fill their prescriptions at CVS or the mom-and-pop pharmacy, and they're not getting the direct translation as to how to use this medication. So they're guessing. So it's important that you know when you get that prescription, how is it supposed to be used, and what is the right manner to take it in. And in addition, ask your physician, ask your nurse, make sure you're fully clear before you leave the emergency department. Drug abuse is another definition. That's when you intentionally take a drug to produce euphoria. Euphoria is that high feeling, okay? Using a drug without a prescription or exceeding the recommended dosage. For example, if I prescribe Tylenol with codeine and I say use it once every 6 to 8 hours, and you find yourself using that 1 pill every 3 hours, that's abusing the drug, okay? Drug diversion is when you take a legal prescription and use it for illegal purposes, whether that's to resell the prescription, whether that is to use it to give out to other people and not use it as directed for yourself. All of those are drug diversion. It's diverting drugs from legal and medical necessary uses towards uses that are illegal, okay? Couple more terms before we get into the lecture. Narcotic, opiate, and opioids. They're often used interchangeably. These drugs are primarily used to reduce pain by interacting and binding to the opiate receptors associated with the nerve cells in all parts of our body, including our brain. So the reason why opiates work for us is because we have receptors, different receptors in our body and in our brain, that these medications, once you take them, they bind to those receptors and they produce the effect and the feeling that they're supposed to have. Similar to antibiotics, we have different receptors for antibiotics in our brain. They bind to the infection and they help to treat the infection, okay? So that this is a physiologic process in your body that's going on when you take this medication. Narcotic. Narcotic is like the overall category of drugs. When you think of narcotic, think big, okay? Narcotic, you can use that generally. The problem with that term narcotic is that it has a negative connotation to it. When you hear narcotics, you think illegal drugs. You think narcotic enforcement agency through the federal and state government agencies. They're divisions that help to capture people who are using narcotics or selling narcotics. So narcotic has a negative connotation to it. So we don't use narcotics as much in the hospital or in the medical world. We try to really identify it in a subcategory, whether it's benzos or opiates or whatever that particular medication is. Opiate. It refers to semi-synthetic or synthetic opiates. Does anyone know what I'm talking about when I say synthetic or semi-synthetic? So there's a such thing as natural drugs, which come from plants that naturally grow in the ground, and we extract the importance of it and able to revert it and use it chemically to create something that can be used functionally for us medically. Synthetic are things that are laboratory grown or based, okay? Opiates refer to semi-synthetic, meaning partially synthetic, and synthetic opiates. Synthetics are manufactured chemically. Semi-synthetic opiates are a hybrid of natural growing opiates and synthetic opiates, and they're put together. It's a combination drug. Some of those examples include fentanyl, dilaudid, methadone, oxycodone, and hydrocodone. Has anyone ever been prescribed any of those or taken any of those? I see a couple hands going up. Yeah, it's very common. And the first thing I want to dispel is this is not a conversation to point fingers or to say, oh, you're using this or you're using that. This is not that kind of conversation. The conversation is to inform and engage, okay? I've taken oxycodone before. I delivered my daughter 7 years ago, 8 years ago, and I was in pain after having that baby, okay? I had to use Percocet and then eventually transition to Motrin. So it's not something that is uncommon. It's frequently prescribed, and it's tried to use for moderate pain. So if you have mild pain, something that's manageable, you want to take something over the counter like Motrin or Tylenol. If you have moderate pain, you usually need something more stronger. So something that is usually prescription. Yes?
How do you determine moderate pain? Physician versus patient?
Excellent. Excellent, excellent, excellent question. So when you walk into the ER, every room has something called a pain scale. For children, it goes from a very sad face to a very happy face, right? For adults, they try to do it on a scale of 1 to 10. Pain is like the 6th vital sign. You know, you get your blood pressure, you get your heart rate, you get your respiratory rate, you get your oxygen saturation, and then the last thing the nurse should ask you is, are you in pain? If so, what is your pain number from 1 to 10, 10 being the worst? Usually moderate is from a 6 and up. Mild pain is from a 1 to 5, and then somewhere between 4 and 7 is ambiguous, okay? Pain is determined by the patient. You have to tell me what kind of pain you're in. Your toothache might be a pain of 1 to 2 for me, but for you, it's how you manage it and how you deal with it. It might be an 8, 9, or 10, and that's not for me to underestimate your pain. It's for us to make sure that we are on the same level and finding the right pain for you. Don't tell me you have a toothache that's a 10 and you're walking into the ER texting on your phone asking me for juice and cookies. That doesn't work. It's not a 10. So you have to be understanding and you have to be informative. So I do that a lot with my patients. Are you sure it's a 10? Are you sure this is the worst pain you've ever had? But you're walking around the ER and you're asking for ice chips. That's not a 10, okay? So I take that into consideration, and it's not a judgment thing, but I need to know how to treat your pain. And if you're a 10, then I'm gonna do stronger medication. If you're a 2, I'm going to do something more over the counter, like Tylenol or Motrin. So we have to meet in the middle ground, and all that is discussion. So it's not just you telling me how you feel, but me interpreting how you feel and how you look and how you're acting, what your vital signs are. It's a combination of all of those things that help us decide what is the right amount of pain medication to give you and what's the appropriate pain medication to give you. One more thing, opiates. It refers to natural substances that come from the opium poppy plant. Opium is a strong pain-relieving medication. Some of those include morphine, heroin, and codeine. So morphine is commonly used in the hospital post-operatively and for our cancer patients as well. Codeine you'll find a lot in cough medicine, and there's also Tylenol with codeine. It's called Tylenol number 3. Heroin is a street drug. You're not going to find that in the hospital, okay? Any questions yet? Yes?
Sure. Are antibiotics considered any of this?
Not at all. Totally separate category. So what we're talking about in terms of opiates are pain-relieving medication. Antibiotics work for infection, okay? We talked about a few examples. When prescription opiates are used responsibly for short periods of time, there's a reduction in pain. And that's the whole goal of opiates. They provide a sense of calmness and possible euphoria and a state of relaxation. Some of the common ones we know are morphine and Dilaudid. Dilaudid is probably the strongest medication that you can get for pain relief in the hospital, okay? It's commonly used for our sickle cell patients, for our cancer patients who have been on pain medication for a long time, and they've built up a resistance to their medication and they need something stronger. Fentanyl. Fentanyl is a fast-acting, quick drug. You'll find it a lot in the ambulance trucks. So trauma patients that are coming in and say they have a huge gash on their leg or they broke their femur or they broke their arm, they want to give you a fast-acting pain-relieving drug. It works immediately and it's short-lived. So fentanyl is usually dosed in traumatic settings. Oxycodone, some of the trade names that we've heard are Percocet and oxycodone. Percocet is a very, very common one. Another one is Norco. Those are two very common pain medications that are prescribed by the ER. Hydrocodone, a lot of people get Vicodin after getting a tooth extracted. It's a very common pain reliever. And we talked about heroin and methadone. Does anyone know what methadone is? Methadone, yes.
Well, it's to help get people off of heroin.
You said it. Perfect, 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 perfect. Methadone is used at substance abuse centers, and it is a medication that is an interim medication. When people have been on heroin and are addicted to heroin, when you try to stop cold turkey, you get lots and lots of side effects. And they're flu-like symptoms, so it's diarrhea, it's vomiting, it's sweats, it's chills, it's fevers. It makes you feel awful, awful to the point that you just want to go back on the heroin. And the goal for using methadone is to try to get you through that period while your body is detoxing from the heroin, okay? So it's used not in a hospital setting as much. Some of the detox centers really use it. Some hospitals have relationships with detox centers and they work to actively wean the patient off of the medications, and it can be used like that, but it's really reserved for those centers that are trying to detox patients, okay? We talked a little bit about why this is even important. Why is this even our topic for today? How did this even become an issue? Unfortunately, many users will become addicted to these effects of the opiates, that pleasure that they get from it. Hence, they will use it more frequently. Addiction has been designated as a national health emergency. Drug overdose is the #1 cause of accidental deaths in the United States. Accident meaning I fell off of a building, I got into a car accident. Those are accidental deaths. #1 is overdose. So that's important to know. Overdose from prescription opiates are the driving factor in 15-year increase in overdose deaths. So 15 years ago, people were overdosing. They've been overdosing all their lives, ever since drugs were created. This is not a new thing, but why is it important today? Why is that an issue now? That's what we need to understand, and why is this even a topic? Because in the last 15 years, the exposure to drugs, the accessibility of drugs, the frequency of prescribing drugs has exponentially increased, okay? So that's why this is important in our discussion. We want to reduce the stigma. This is not a hush-hush conversation. Oh my gosh, she's using Percocet, or oh my gosh, do you see him with the Tylenol? It's not that kind of conversation. We don't get anywhere when we talk like that. We have to talk openly, we have to talk honestly, we have to engage each other. We have to make sure that we are reducing the stigma and clearing that out the room so that people feel comfortable to discuss this. I have patients that come to the ER and they're like, okay, you know, I just broke my arm. I'm putting you in a splint, I'm putting you in a sling, and we're talking about pain control and what we're gonna do after that. And I'll say, okay, this is a pretty bad break. You're gonna be uncomfortable for the next 2 to 3 days. Why don't I go ahead and prescribe maybe a couple of Percocet tablets for you? If you don't tell me that you have a drug history and that you were addicted to prescription medication for many years and you recently got off, I'm not gonna know that. It's not in your bio. I can't read that on your file. It's not listed as your medical issue. I would never know that. And what I would do is become your supplier, and I'd give you temptation. I don't want to give you 10 pills of Percocet if you formerly had an addiction to Percocet. So it's important that you feel comfortable with me to tell me that and say, Doc, I really appreciate it, but I just got off of Percocet last year. You know, I had a bad bout with addiction for it. I want to make sure that doesn't happen again. And of course, me respecting that and understanding that and being proud of you in that decision, I want to make sure that I don't revert you in any way. And I want to make sure that I prescribe something that is A, pain relieving for you, and non-addictive for you, okay? So you have to feel comfortable with me, I have to feel comfortable with you, and the only way for us to do that is to kill the stigma behind this whole conversation.
What would be a drug that you would prescribe if someone were addicted to something and they were in pain?
Absolutely, we would start with probably Motrin 800, which is a prescription strength Motrin. Motrin comes in different amounts. You can use as little as 200 milligrams, 400, 600, 800 is prescription strength. So Motrin 800, which is non-addictive, which can be used every 6 to 8 hours, is a good option. And of course, you have to consider what are the other medications the person is on, how does it interact with their body, make sure they're taking it with food. So those are also things to consider in the conversation. The amount of prescription opioids sold to pharmacies, hospitals, and doctors' offices has quadrupled since 1999 to 2010. Yet, you don't hear a higher amount or a greater amount of Americans saying, I'm in more pain. The pain amount has not changed. So we have to understand, why are we prescribing higher doses of medicine for pain relief when the pain is the same amongst the audience? What is the drive? Does anybody see that? What is the drive? Why are pharmaceutical companies pushing more drugs to hospital offices and doctor's office, and why are we prescribing higher levels of medication for the same amount of pain? The pain has not changed. A broken arm is a broken arm. That has not changed over the years. But we are using drugs that have a much more addictive property to it and a higher pain relief rather than starting with more of an entry-level drug like Tylenol or Motrin. Why is that our first jump? So it's about changing your mindset. It's about knowing what works for you and making sure that you are having this discussion with your doctor. Yes. Yes, absolutely. Right. Absolutely. So let me recap for you in case anybody did not hear. We were talking about addiction. He mentioned that there are a lot of patients that come to the ED who are addicts, right? They're addicts and they come to the ED specifically to get that prescription. And what are they doing with it? Are they taking it and they're using it to resell or to use it for their own personal gain? How do I decipher who is an addict versus who is a non-addict? And there is a organization, I'm sorry, not an organization, there is a computer database that is created in Florida called eForce. eForce was created in 2009. We're going to talk a little bit more about it for all narcotic prescriptions in the state of Florida. And we can see where you filled the prescription, who prescribed it for you, how many pills did you get, did you take the whole prescription? That is something that is required for us to use when we prescribe narcotics. Or if there's any suspicion that this person is hospital shopping or doctor shopping, or are they using different names in the emergency department? All of those things come into mind. But E-Force was created by the state to help physicians and prescribers to understand how much narcotics this person is getting, where they're getting it from, and who's their supplier. Are they using it appropriately, inappropriately? All of those things. Because you want to make sure that you're doing the best thing for the patient. Originally, opiates were reserved for post-operative patients and cancer patients to treat moderate pain. So remember our pain scale, 1 to 10, moderate pain being a 6 or higher. And cancer patients have a higher tolerance for pain because usually they've been on pain management medication for years. So when they come into the hospital, I can't give a cancer patient Tylenol. They're going to look at me like those are Skittles. They're going to laugh at me. It's not helpful for them. It's not beneficial for them. I need to go with a higher dosage of pain medicine. So those are all things to keep in consideration. Post-operative patients, if you just had this huge vascular surgery and you're trying to recover from that and you've been in the bed and you can hardly move, I can't just give you 2 Motrin and think that you're going to be okay tomorrow. I have to think that, okay, maybe this person needs something a little stronger. Let's discuss what our choices are for this person. Initially, physicians prescribe these medications for short periods of time. Over time, they've been doing it for long-term use, and that's how we have all these pain management clinics popping up, right? So if a person has, quote, chronic pain, you'll see people with prescriptions for 30 to 60 days of pain medicine. So they're called long-term prescriptions. And these powerful medications are used for people with chronic arthritic pain, and this epidemic of opiates arose from that. If you're just getting a prescription for 2 or 3 days for Percocet, you're not going to get addicted from 6 pills of Percocet. If you take them all one time, you'll probably have a really bad side effect, but you're not going to get addicted. Addiction is chronic use, long-term use for something. And I don't want you to leave from this lecture thinking like, oh my gosh, please don't give me these Vicodin tablets for this toothache or this tooth pain. That's not what it is. What I don't want you to do is get 40 Vicodin tablets for a toothache and use one every 6 hours for the next 3 weeks. So I want you to understand what you need, how often you need to use it, the fact that you can stop it at any time. It's not a medication that you have to wean off of. If you're feeling much better and your pain is much better, don't use the Vicodin. Scale down to the Tylenol, okay? So remember, all medication has an effect on what you're currently taking. If you're mixing pills, if you're doing things out of sequence, sleep aids on top of opiates together, when they're used in combination, can cause respiratory depression, meaning that your ability to breathe for yourself is depressed because A, your body's trying to go to sleep, and B, it's extremely calm because of the pain medication. So you're putting yourself at a higher risk when you're combining those medications.
What if the doctor gives you, let's say, Valium, and you're taking this for a period of 25 years because you're anxious or you don't sleep that well and you do have a heart condition? At the end of that term, they tend to get Parkinson's disease.
Okay, that's a whole nother discussion. So her question was if you've been on Valium for 25 years and at the end of that you develop Parkinson's disease. I can't speak to the specific effects of Valium and its relationship to Parkinson's disease because I have not researched it enough, but that's a whole nother discussion because Valium is used as a muscle relaxant and anti-anxiolytic, so it has other properties to it. And if you've been on it chronically, then your body has a certain level of tolerance to it. And if you've been on the same dose chronically, then it's obviously effective for you because you're continuing to use it consistently. So Valium and its relationship to Parkinson's, I don't know about, but we can do a little bit more research about it and hopefully talk about it offline.
Because my husband developed Parkinson's from that drug.
Got you. Let's talk about that one offline and keep our focus back on the opiates. Yes?
I have a question.
Yes? Oxycodone and hydrocodone, yes.
Okay, do they have generics? And are generics the same, really, or are they different?
Okay, so when a drug first hits the market, it's patented. It's patented for usually 10 years so that you can't get spin-offs of that drug. You can't get generics or other types of drug based off of that particular chemical formula, right? So you have that patent for 10 years, and then once that patent expires, then you start to get other drugs that are made that are similar in efficacy and in composition of the original drug. Generics versus brand name really should be equivalent in its effectiveness for you, but everybody interprets a little different. I have a lot of patients that come in and say using generic hydrochlorothiazide for my hypertension is different versus using brand name hydrochlorothiazide, okay? Remember, between each drug, there's a slight tweak. If it was identical, you wouldn't be able to market it as two different drugs. It could only be marketed as one drug. So something is a little off between a generic and a brand, okay? And whether there's an additive to it or something's taken away, there's something that's slightly different in order for it to be called a whole different name and to be able to be marketed like that. In terms of hydrocodone and oxycodone, yeah, there are medications that you can use that are generic. A lot of those drugs are combination drugs. For Percocet, you'll see hydrocodone and acetaminophen combination, 5-3-25. So you have your acetaminophen component, your Tylenol component, and your hydrocodone component. The 5 milligrams can go from 5 to 7.5 to 10 to higher dosage. That is your pain control. And the acetaminophen combined with it helps with the inflammation component to it. So it's a combination drug, and it's brand or traded as Percocet. But can you get generic versions? Absolutely, you can get generics. Will they be as effective as the brand? Hard to say. Each person is a little different. That's like going to the store and getting generic ibuprofen versus Motrin. They both have the same amount that you're supposed to use and the same effectiveness, but everybody responds a little different. So a lot of that has to do with what you're currently taking, what your current diet is, how you interpret those drugs, and how your body receives those drugs. One more question before we go on.
Isn't it the additives that are the difference between the generic and the brand?
Yes, absolutely.
And it's the additives that might or might not affect you. And
Absolutely.
so I think, well, I
Yep.
won't comment.
Perfect choice. Prescription opioid use amongst subgroups. So we want to break this down. Prescription opioids varies amongst age, gender, and ethnicity. We know that our older patients, 40 years or greater, are more likely to use prescription drugs than age 25 to 39. Usually our older patients have established medical diseases and are coming in because they either need refills of their medications or they have this disease process that they need to treat. Usually our healthy age group is 20 to 39. You're not having hypertension, you're not having chronic arthritis, you're not having all of those things, diabetes, and this age group, 20 to 39 is the highlight of your life, right? You're supposed to be your healthiest, your fittest, your most active. As you start getting greater than 40, you start to develop certain things. Your vessels start to loosen, things start to widen a little bit, your weight gain and your metabolism changes, which has long-term effects on you. So that's why that age group, 40 and older, they're more likely to use prescription medication, right? Women are more likely to use prescription opiates than men. That's a new fact. A lot of people didn't know that. And that is just a preference. Women are more likely to go to the doctor than men. Women are more likely to be proactive in their health than men. You get married because the guys need the women to take care of them. They need them, say it again. The guys need the women to take care of them, to schedule their doctor's appointments, to make sure they do those annual exams, to make sure they're doing the preventative health, they're eating right. So that combination of marriage helps to increase your lifespan tremendously. You guys are taking care of each other. So that's why women are more likely to use prescription opiates than men, because they go to the doctor more frequently than men. Non-Hispanic whites are more likely to use prescription opiates than Hispanics. So whites are more likely to use prescription opiates than Hispanics. It's just something they found in their ethnicity when they did the charts to look at the age across several age groups and gender groups and across different ethnicities. They found that whites were more likely to use prescriptions than Hispanics. Deaths from opioid prescriptions, drugs like oxycodone, hydrocodone, and methadone have quadrupled since 1999. So 99, at that point in time, around that 99-2000 mark, is when the drugs started to infiltrate the market and they started to grow. And once they start to grow, they took off. So that's why 99, you'll see a lot of the data starting from that 99-2000 era to present. The most likely deaths from opiates are due to oxycodone, hydrocodone, and methadone. Those are like the three most common ones in the opiate category. Remember, we talked about narcotics as our overall umbrella. Underneath that, we have opiates and opioids. And of those, methadone, hydrocodone, and oxycodone are the most common opiates that cause death. Okay? Yes?
I would like to know, do you find that people take the drug exactly at this hour? Or is there a little leeway between a medication? Because the doctor may say take it at night, take it in the daytime, but you might take it a little late or an hour earlier. And what effect would that have?
That is individual based. No, people don't take things the minute they're prescribed. Life. You know, you're running around, you don't have your medication on you, you're trying to get multiple things done in one day, you might be off by an hour, you forgot to eat, therefore you can't take your pills right now. So life happens, and people don't take things at the very moment. I find that my patients who have alerts on their phones or alerts on their watches that say, hey, take your meds right now, are more consistent with taking their medication versus our patients who are at home and are trying to remember to take it, if that makes sense. So when you have a motivator or somebody dispensing your medication for you or an alert telling you to take your medication, you're more consistent in how you take it. Does that have an effect on you? It depends. A lot of drugs are time release. So especially for blood pressure medication and pain medication, they're only good for a period of time. As that starts to run out, then you need another dose. So as your blood pressure pill, which is only good for 12 hours because you're supposed to take it twice a day, if you forget your overnight, you're going to wonder, hey, why is my blood pressure high the next morning? That's because your medication ran out. It did what it was supposed to do for 12 hours. But the other 12 hours, your body did not have it, so it didn't work in your body. Same thing like pain meds. They wear off. Everything wears off. It's only supposed to function for a period of time. And that's why sometimes you have to redose. All of this is to say that it's becoming increasingly difficult to identify those who need help, to identify individuals who are actually addicted to prescription opiates. We wouldn't think women have greater prescriptions than men for opiates. We wouldn't think that our older age group, 40 and older, who know better, who have more life experience and more exposure and are more knowledgeable, have a higher risk of prescription opiate abuse than younger patients. So this goes to tell you that there is no face of opiate abuse. It is non-stereotypical. So we have to kill that immediately. We can't think it's just the homeless person on the corner who does not have, access to medication or buying street drugs. Opiates are coming from your physicians, from your doctors, from your emergency rooms, from your primary care doctors, your pain management clinics. They are prescribed, you're given a prescription, you're taking that to the pharmacy, you're filling it. These are legal medications that are being used in an abusive manner. So that's why it's becoming an epidemic, okay? So now that we have identified that it isn't anyone that we've never seen before, this is our brothers, our cousins, our grandchildren. These are people in our lives, in our families. And I'm sure everyone has known someone who has been addicted or is struggling or battling with addiction. And addiction comes in many forms. The most common is prescription pills, and that's what we want to get across in our message today. If you have any suspicion or you're concerned, make sure that you address that. Don't let that linger. I had a girlfriend in college who started taking light stuff. She started taking Motrin and Tylenol, and then she had some cosmetic surgery. She got some liposuction done after her baby. She got her, breast implants, and she needed stronger medication for recovery. She couldn't get off of that. So eventually she got to the point that she was taking so much pain medication, it caused an arrhythmia in her heart, and she died at 31. So it's not something, and this is a girl with a master's degree, functional, every day, has a young daughter. All of these things make you think, these are our friends, these are our family members, these are our children. And it's important to have these conversations with them if you're concerned that there could be a possibility that they might have an addiction issue.
I want to ask you, those that are not legal drugs, there was a case, if you think maybe a month ago, with a young 6-7-year-old was in a house and the parents were selling, they said it was opium. I don't know if that's the case or not. Is there powder? Is there pills? He just touched it and he passed away. I don't know if you heard that case or not.
I haven't heard of that particular case in Florida, but I've heard of similar cases.
Miami.
What he's saying is that there was a case for a young child who was living in a home where the parents were, sounds like, growing the opium plant, and they were using it, whether they were grinding it or concentrating it down to manufacture it into a powder, and the child touched the product or was exposed. Two ways you can get exposed. You can inhale it. It goes in through the nasal cavity, into the body, into the lungs, and works throughout the entire body. You can get it in your mouth by tasting it, so sublingually, putting it on your tongue or underneath your tongue or on your gum lines where it's absorbed into the bloodstream. Touching it, transdermal. You can get things absorbed into your skin that way as well, too. You'd have to touch a lot of it in order for it to be that detrimental to you. The other two ways, inhaling it and tasting it, are faster acting than actually touching it. But for a 6-year-old whose body size and capacity is maybe 35 pounds versus an adult who has an adult size and weight and metabolism and strength, it's a very different amount that one would need. So even small amounts of exposure to that medication or that opiate pill at the time could have an adverse effect on the child and cause heart arrhythmias, can cause breathing issues, can cause various other things that might cause the child to die.
The epidemic is not only doctors, that heroin addicts are going to that drug because it's easy to make and it's being exposed to our community. Is that a fact?
So we're going to talk about that. His question was, is the epidemic coming from physicians? Are we the only source for contributing to the epidemic? Absolutely not. Absolutely not. Because if I'm not your supplier, someone else is, okay? And whether that's another hospital, another physician, someone who's selling it illegally, friends who are giving it to you, we have another chart that's going to kind of go through that, but I'm a part of the problem. And that's what I want to acknowledge in myself, understand my role that I play in it, and figure out how I can do better. Yes?
Can you have an arrhythmia, say, an extra heartbeat for decades with no consequences?
Yes. So he's talking about the actual way that the heart beats. A heart beats in something called sinus rhythm, where you have consistent beats every few seconds or second. It's a consistent beat. Arrhythmias is when your heart beats in abnormal patterns and they're not consistent. You might have drop beats, you might have beats that are prolonged, or you might have something called atrial fibrillation where it's out of sequence in terms of how your heart beats and you need medication to control that. Can you be asymptomatic from that? Yes, because it can be something called paroxysmal arrhythmia, where you only have it for periods of time, maybe a few seconds, then it goes back into sinus rhythm, or it might happen so frequently for you that your body adapts to it and it thinks this is normal for you, okay? So that is more of a cardiac workup, not related to opiates, but something that should be explored with your cardiologist and do regular EKGs and stress tests, all right? Let's move on to our next slide. So we talked about overdose rates are highest amongst age 25 to 54. They were highest amongst whites and American Indians compared to blacks and Hispanics. Men were more likely to die from overdose, but the mortality gap between men and women is closing, and overdose does not equal death. Does anyone understand what I say when I say overdose does not equal death? Many people think because you go to the hospital and you overdose, say that you're found and you have a substantial amount of opiates or drugs in your system, that is technically an overdose where you become unresponsive, it's difficult to awake you, you might need assistance breathing, you might need some machines to help restart your heart, all of those things. Just because you overdose, you don't die. That's not the direct correlation all the time. Many people overdose and live to tell the story that I overdosed. You hear a lot of those recovery stories. Like, man, I was near death, I overdosed, but I came back. And many people learn from that experience or go on to do more drugs and see how far they can take it. How can I push the limit? How far can I go? Everybody has a different approach. Overdose does not mean that you die. And I want you to understand that because a lot of these facts that I'm giving you and these little jewels that I'm dropping are related to death due to overdose. So that's a different kind of thing versus overdosing in and of itself. Those facts related to people who have overdosed and continue to live are different numbers, okay? Similar, but there's a distinction, all right? What did we want to gain out of this lecture? We talked about the importance of understanding the issue that is amongst our community, all of us. We talked about how important it is to have clearer prescription guidelines. When I say that, that's my role. How I prescribe to you, what I'm prescribing, how many days, that you have clear instructions on how to use it, how to discard it, and what to use. The next step is legislation. You know, we have to talk about how this needs to be regulated and adjusted and changed and what rules can be implemented from legislation to help tighter index and control on that. We talked about reducing the stigma. This is now everybody's conversation, not just a conversation between me and the person on the street. This is everyone's topic, everyone's conversation, including conversations with our children, with our high school children, with our elderly patients who might not be reading the directions appropriately. We talked about patients who have language barriers and might not understand the directions, right? Next, we're going to talk about unifying the message. So I hope I've made that very clear to you that the goal of this session today is to make sure that we all take something away from it in terms of how we can take it, recycle it, share it with someone else. Because if not, it's not effective, right? If you come here and you're just lackadaisical and you're not participating and engaging, you're not gaining anything from it. You're just a present body in the room. I don't need that. I need you to take something away from me, and more than that, let's go the extra mile. I need you to teach me something. Your questions are important. Our interaction is important to me. Let's talk about coordinating the efforts. So we have identified patients who are addicted, identified the patients who have abused this medication, and let's coordinate the efforts to get them to the appropriate addiction specialists and the appropriate support groups. Yes. Absolutely. So her question was, what effect does opiates have on the other medications that you're taking? That is for your physician to know everything that you're taking. That's why when you first come in and they're doing that triage in the emergency department, they're asking you, do you have a list of your medications? Do you have the dosages of your medications? How frequently are you taking it? Is this a current list? So we go through all of those things because before I prescribe or give you anything, whether that's in the ER or medications for home, I need to understand how that could potentially interact with any of those meds. Everything has an interaction. And that's why sometimes you spread out your medication throughout the day so that you're not overlapping, because certain things might make you feel worse if you take it with other medications, right? So that is for me to review your list, make sure I'm not giving you something that can cause a negative or adverse effect on you. But everything interacts in itself, and it has to work holistically in your body in order to be efficient and effective, right? Healthcare provider, my duty today is to share the best practices, to increase awareness with you, promote education, and promote and improve treatment through a unified approach to combating this epidemic, right? So over 76 million people in America suffer with chronic pain. Chronic pain is pain that's greater than 3 to 6 months, right? If you come in and you broke your arm, you're gonna have pain for maybe a week, and maybe a couple weeks thereafter as you're in the cast and you're healing. Bones take about 4 weeks to set and heal. Chronic pain are people who live with daily pain, daily backaches, daily arthritis. Something that is chronic is over 3 to 6 months and beyond. So that way you can make sure that you are addressing it. The combination of people who have diabetes, cardiac disease, and cancer are less than the people who have chronic pain. You know, there's over 76 million people in the world, or in the United States, I should say, that suffer from chronic pain. Each day, more than 1,000 people come to the emergency department and they're treated for not using their opiate prescription appropriately. So there are side effects to all of these drugs, as we talked about, right? Not using it appropriately, whether you don't understand the instructions, whether you are using it for pain that doesn't necessarily determine or need that strength of medication, whether you're taking it too frequently or infrequently, that it's not being effective for you, whether you're combining it with other drugs and you're having an adverse side effect. Everything that you take has an effect. Anything you put in your body, anything you eat, you drink, you absorb, any pill you take has an effect on you, has an effect on your body, and has an effect on your mind. So opiates, remember, cause that euphoric sensation, that high, quote unquote, that general sense of calmness and pain relief. So we're not just talking about your physical body, we're talking about your spirit and your mind as well. Yes?
How does marijuana fit into the picture?
So marijuana is going to be another discussion. Marijuana is promoted as a, quote, gateway drug to help this opioid epidemic. Marijuana has non-addictive properties. It is legalized in the state of Florida for medicinal use. There are 14 ailments that qualify for medicinal marijuana use. About 29 states right now are approved for medicinal use for marijuana, and a couple more recreationally. But in the state of Florida, the debate and the discussion and the approval is for medicinal use of marijuana. It is promoted right now to try to help people get off of some of these opiates and to be marketed to use for pain and inflammation relief.
So it's considered non-addictive?
It's non-addictive. There have been no actual recorded deaths from marijuana or cannabis use.
Out of this epidemic problem, has it been determined how many people are bona fide prescription users for chronic pain and how many are abusers?
Good question. So I gather from that question you're saying what percentage of this epidemic is caused by the physicians?
Is it being boosted because of the abusers? Or, you know, then we know where to look sometimes.
Good point.
to correct it.
Good point. It's hard to say because you can get opiates from many different outlets right now. It's not only your prescribers. Your drug dealers are your friends, your neighbors, somebody that just hands you that Percocet pill and say, hey, take this, feel a little bit better, this might help you. That's your supplier. It's not me. I gave the drug to your neighbor, but your neighbor gave it to you. So I'm not your direct supplier, but your neighbor is. And that is how the cycle becomes mished and like a big bowl of soup. You can't really tell who's giving who what. I know who I prescribed it for, but once you take that bottle and those pills and how you use it, whether you sell it, whether you ingest it all yourself, whether you crush it and mix it with other drugs, whether you smoke it, I don't know. I know that I gave it to you with the intention and directions on how to use it, but what you do with it once you leave me, it's out of my control. So it's hard to say amongst the millions of people that are using opiates, what percentage of that actually comes from prescriptions that are given legally to patients.
No, that wasn't my question. It's what percentage of the increase is due to people that are using it for other purposes than what it's intended. In other words, a chronic pain person
Right.
might become, is that the reason for increase? Because their pain is so severe that they're the cause of the increase? Or is it the drug people, is it people that are abusing them? And then we have to look for another reason. Why? what are we in our society, or what are, what's happening to make them resort to this for those reasons?
So
I don't know
chronic-
whether
It's, the
Like,
question is a little unclear, but from what I gather, and I'm sorry if I'm misinterpreting you, is that people who have chronic pain eventually build up and create a tolerance and require more pain, right? More pain medication, higher doses of pain medication. That's one aspect of it. People who are taking it and abusing it, whether they're doing it for the goal to get high, is a different aspect of it. And I think you're asking me how many people are doing what?
what's causing the quadrupling of the statistics?
What's causing?
Is it from the legitimate use or the abusive use?
No, the quadrupling is a combination of the abuse, and with legitimate use, you have a higher demand as well, too.
But we don't know what the difference is.
It's all one
In terms of the statistics.
statistic.
Because if you want to correct it, sometimes you look at it and you say, well, if it's coming from the chronic users, then let's see, are we as as the providers really doing our job? If it's coming from the abusers, then we say, let's go to the sources from where it's coming maybe, or look at the reasons why they're abusing.
Those are great solutions and great ways to help address what is going on in the big picture of it. In terms of chronic abusers, you have to go to the source, which would be the physician who's supplying the medication. So remember we talked about long-term use of opiates and how patients are getting prescriptions for 30, 60, 90-day supply. A lot of these drug companies want you to do mail-in and get your prescription at home for 90 days so they don't have to send it to you again. So they're giving you longer supplies of medication. With that being in your house, if you have a 90-day supply of Oxycontin in your house, and say you only take one every couple of days or one every couple of hours, you're going to have an excessive amount left over. Having that medication is potential for other people in your household to start using it. So actually distinguishing, who, what, when, where, why, and from how is very hard at this time. I think that is a big picture. I think it is a great goal to try to identify how much of this is chronic pain, how much of this is abuse, how much of this is coming from where. But it's going to be very challenging because, as we addressed before, you can't exactly say who is getting what from where and how. I watched a couple of videos on YouTube, and you would hear former addicts talk about, I got the pain medication or the drugs. A lot of them got them from their own household. Whether their grandmother was on Percocet for arthritis, they would just take it from there. And then over time, they would notice that they needed more, and their prescriptions were running out faster. So someone who's not keeping track of how much they use every day, they're like, oh, my prescription's up. Let me go to the doctor and get another one, or let me call in for a refill. So it's hard to say specifically, but it is part of the big picture that once you can identify that and identify who's doing what and what role they're playing, then we can start getting to the bottom line of the issue. I think with our chronic pain patients, it is important because I don't want to give you a 90-day supply. What I should be doing is trying to find the minimum amount of pain medication you need to achieve the maximum relief. Not just giving you a consistent supply of medication without trying to alter or provide other alternatives to your pain relief. And whether that is adding meditation to your regimen, whether that's adding exercise to your regimen, whether that's adding other natural or holistic approaches to pain relief. All of those things have to be done in combination, all right? Let me go on to the next slide right quick, and then we'll come back for a few more questions. I just want to get through everything with you guys, okay? So fact, 142 people die every day in the US due to opiate overdose. Drug deaths are listed from the greatest to the least. From 2016, we see that cocaine is still number one, still the highest on the list. Under that, we see benzos, we see fentanyl, morphine, fentanyl analogs, heroin, alcohol, oxycodone. That whole category fits into opiates, right? So it's a large portion of drug overdoses and contributing to opiate deaths. In 2016, they have a reported of total drug overdoses of 63,000. And then the amount of deaths that involve opiates are 42,000. That's about 66%. The number of opioid-related deaths between 2014 and 2016 increased over 30%. That's what triggered this whole conversation. That's what triggered this debate and this discussion. On this map here, we see dark blue, light blue, medium, right? The darkest blue states have the highest rate of opioid overdose deaths, okay? And they are due to prescription opiates. We see Florida on there. Number 1, out of California, Ohio, New York, Michigan, and Florida. What do you think was number 1? California? No, it was Ohio. Ohio. What are they doing out there in Ohio? What's number 2? California, Michigan, New York, or Florida? It's us. It's Florida. We're number 2. Number 3 was California. Number 4 was New York. And number 5 was actually Massachusetts. Okay? Texas is in the middle range, so it's in the middle blue area. It's not in the extreme navy blue. We're in the extreme navy blue area, so that's not good. Sources of prescription opiates over the past year and non-medical users, right? We talked about where are people getting these medications from. So looking at our list, that tall gray column is given by a friend or a relative for free. So most people, the first time they try opiates, they're getting it from their neighbor, from their friend, from their relative that's saying, hey, give this a try, see if that helps to relieve you. The red column right next to it is a prescription by more than one physician. And as you start to get further down, you see other sources of where people are getting these opiates from. They can be stolen from a friend or neighbor. They can be bought from a friend or a relative, bought from a drug dealer or a stranger. And the last category is other. What you're looking at is from January to December. So it's going from day 1 in the year, which is the far left column, and it looks at the first 30 days, the next window, which is month 2 to month 4, and then month 4 to month 8, and then the last quarter of the year, right? You'll see as the gray number starts to decline, remember the gray number are the amount of prescription drugs that are given by a friend or a relative for free. As you get further into the year, that starts to decline. They're running out of their medications. Remember, your insurance is getting low. Your ability to fill your prescriptions is sometimes getting a little more difficult. Maybe you've exceeded your quota for the year. Whatever the reason may be, the prescription amount is decreasing. So your friends have less pills to share. You'll also see the red number starting to go up, the red bar. As the red bar starts to increase, that means that more prescriptions are being given out by physicians, whether that's physicians in the ER, physicians in the hospital, whoever that is, right? As you get towards the end of the year, people start to get desperate because they don't have access to that prescription and access to their medication. So they start to doctor shop. They start to go to different hospitals. They start to use different names. They try to get what they can from various sources. What has Florida done to address that we are number 2 in the amount of prescription-related opiate deaths? What have we done? What has Governor Rick Scott done? What are all the articles you're reading in the Miami Herald? What are you hearing on the news? What is CNN talking about? What has Rick Scott done to say, hey, this is an epidemic, and specifically it's an epidemic for our state, Florida, which is what we're concerned about right now. He declared it a public health emergency in May 2015. With that declaration, he's allocated and requested $50 million in funding. For that $50 million, he wants that to be used for the state in various ways, proposing that physicians now have a 3-day limit on prescribed opiates. I'm not talking about pain management doctors. I'm not talking about your primary care doctors. I'm talking about ER physicians. A good bulk of these prescriptions are coming from us, from ER physicians. So now I can only prescribe you a 3-day limit of pain medication. So if that one Percocet is to be used every 6 hours, the maximum I can give you in one day is 4. Multiply that times 3, I can only give you 12 pills. That's it. Now, I try to be considerate for people who have a higher tolerance and be able to gauge a little bit more or a little bit less if you don't need it, but I'm within a window that I cannot exceed. I cannot just give you 50 Percocet tablets and say, hey, have fun, because they're going to come back looking for me. It's my license that's on the line. That's the question that they're going to see Those red flags are gonna pop up when you go to the pharmacy, and the insurance companies are gonna come calling me like, hey, you're in the ER. Why is this person getting refills on Percocet from the ER? You know, it becomes questionable, and you become a physician that they start to monitor and start to look at your drug practices and your habits, and you become under probation. So not only is it affect you, but it affects me as well, and it jeopardizes my license, okay? They also want to fight unlicensed pain management clinics. Everywhere is popping up saying, hey, I'm a pain management clinic, come here. Hey, I licensed to prescribe pain medicine, come here. You'll see those on every corner now. They're coming up like liquor stores. They're very easy. A lot of those places you go into, they're taking your money. They're taking your money. You're not getting the prescription that you think you need or deserve, and you're not getting the treatment that you need or deserve, or even understanding what other options you have. So you want to try to fight those unlicensed pain management clinics and make sure they are shutting down and not abusing patients, right? Require all healthcare professionals to participate in a statewide database that monitors prescriptions. So we talked about eForce, right? That's a statewide database that logs every single patient that is prescribed a narcotic medication. It shows you what doctor prescribed it, how many pills they prescribed. It tells you what pharmacy they filled it at, and did they get the full prescription. And also develop programs focused on substance abuse treatment, counseling, and recovery. So not only do we need to identify who's having the issue and what our role is in the issue, we need to take the next step and talk about how to help that person recover. We can't just say, hey, you got a problem, fix it and deal with it. We have to show you that there are other avenues for support. Because if I don't give you that, then I've done you a disservice. I've done you an injustice. If I can't tell you how to improve or how to get better, then what was the point of me identifying it? I just said, hey, you got an issue, good luck. That doesn't help you. I haven't done my job. So it's very important to develop programs that focus on substance abuse treatment, counseling, and recovery. Almost done, just a few more slides to go, and then we'll take questions. We talked about eForce, created in 2009 for safer prescribing of controlled substances. And let's talk about a few solutions. So improving prescription opiates, expanding the treatment of addiction, and reducing access to illegal opiates, right? We also want to improve exposure to opiates. We talked about that case of the baby and opiates being in the household, how to properly close the bottles and keep them out of access to people who should not have it, prevent abuse, and stop addiction. Expand across evidence-based substance abuse treatment centers, which are called medication-assisted treatment. So if I have a patient who's abusing heroin, we talked about the withdrawal signs from heroin. It feels awful. You feel like you have a terrible flu, diarrhea, cough, cold, body aches, sweats, chills. Once people start to experience that, they're more likely to go back to heroin because they don't want to push through those symptoms, which can last up to a week. So there are medication-assisted treatment programs, i.e. methadone, and other medications to help get you through that period when your body is trying to detox and get clean. We want to make those treatment centers more accessible, and we want to be able to let them know, hey, this is what your option is, this is here for you. If you'd like to take advantage of it, let's help you work through that. Expand access and use of naloxone. Does anyone know what naloxone is? Narcan, there you go. What is Narcan? Narcan is a quick shot. It can be done intranasally through the IV to help reverse your overdose. So if you have somebody that has overdosed from opiates and is passed out, you give them a shot of Narcan and it should help bring them back. It should wake them up. They feel pretty bad afterward. They usually end up vomiting and they're really mad that you messed up their high. But you saved their life. That is exactly what they say. And they're like, oh, why did you do that? I didn't want that. I was in that euphoria. I was relaxing. I got the sun on my face. And then you woke me up and I started throwing up. So they really get mad at you, honestly. Narcan is found on all of the ambulance trucks. It can be administered by EMTs, right? And now they are doing classes so that the police force, especially the DEA force, the drug administration, carry Narcan on them. For two reasons. One, if one of their coworkers is exposed to a drug, whether they walked into a room and accidentally inhaled cocaine or was exposed to it or other medications, they're able to use the Narcan and revive them, and also to revive patients who are passed out or unresponsive from the abuse of the medication, okay? So they're starting to train police officers how to use Narcan now. Promote the state prescribing drug program, the E-Force. It is optional right now for prescribers to use it. They want to make it mandatory that you are looking up any patient that you are prescribing medication to. I use it frequently. I try to look through the past medical history to make sure what you're getting, that I'm giving you the right medication. E-Force is important because it lets me know if you're going to other places to get it, and especially for those patients who are coming in and they're just like really pushing. They're really pushing. I had a patient the other day, elderly patient, who said that she didn't feel too good, that she was having some pain, and then she had a grandson with her who was like maybe 22, and he kept saying, I think she needs Vicodin for home, and high-dose Vicodin. She's been taking this for a while. I'm like, why do you think she needs that? She's 82. This doesn't make sense. So I look at her database, and what he's been doing is, because he's now red flagged, he can't go anywhere. His name is all over the prescription monitoring system as being abused for these medications. He has started to push that she get the prescriptions in her name, and then he takes her prescriptions, okay? So you have to just be mindful, be aware that this is happening. It's an issue, it's a problem. We also want to improve detection of the trends of illegal opiates by working with state and local public health agencies and medical examiners and law enforcement, all right? We talked about alternative treatments. So it's not just addressing the pain. The pain is the main reason why you came, but there are many other things that go along with the pain. Not only if you're in pain, you are less active. You are unable to cook for yourself. You're unable to get out of the house to fill your medications, to go to the store. It's more of a social component that goes along with the pain, and how does that pain impact your lifestyle? So we need to talk about lifestyle adjustments and what I can do to help make sure that your life still goes on and your day-to-day activities still function. So can we get meal delivery services to your home? Can we get a neighbor to check on you every few hours? Can we have somebody come to your house to do your physical therapy so that you don't have to leave for that? Can we have a dialysis agent come to your house to make sure you don't miss any treatments because you're in pain? So all of those other things that need to happen for you every day to make sure you are in tip-top condition and shape, we want to make sure that we are addressing all those other components and that they are coming to you and making sure that the pain is not inhibiting you from living and from continuing to be the best person you can be. Behavioral therapy. Behavioral therapy is important because we want to talk about using the least amount of pain medication to achieve the maximum amount of relief. So not only is that a prescribing issue, but it's also a mental issue. I have patients that come in and say, I use 10 milligrams of Vicodin every 6 hours, and that is all I will use. It is the only thing that gives me relief. And they are adamant that this is what they need and this is what they take, and they don't want to hear anything else. That's a behavioral issue. I have to talk you down. I have to talk you off of the ledge, like pull it back a little bit. Try something else. Let's see what we can discuss. Have you tried breaking your pills in half? Have you tried spreading out your dosages? Maybe you don't need it every 6 hours. Maybe you can do it every 9 hours. Things like that. So we want to talk about behavioral modifications. Acupuncture is promoted to relieve pain and massage. I always talk about stretching and massage, especially for patients who have lower back injuries or muscle spasms. It's not just you taking the pain medication. You got to be able to stretch. You got to be able to loosen that muscle in itself, and massage is a great technique for that as well. 3 more slides to go. Prevent, reduce, and reverse. That is my entire theory. If you prevent people from starting opioids, you can reduce the opioid addiction and eventually reverse the possibility of overdose, right? So we talked about preventing people from starting them. We want to make sure that we are minimizing the amount we're prescribing, and we are reducing prescription opioid painkiller abuse, improve opioid painkiller prescribing practices, and identify high-risk individuals. We talked about some of those high-risk individuals. Reducing opioid addiction, ensure early access to medication-assisted therapy and treatment programs, treat people addicted to heroin or prescription opioid painkillers with this medication-assisted treatment program. which combines the use of methadone. We talked about methadone being able to help patients bridge from when they come off of heroin to get to a clean point in their body, Suboxone as well, and Narcan, right? You want to do that in addition to counseling to make sure that they understand how to cope now, and in addition to behavioral therapies. Now that I'm not using this heroin or this opiate, what else can I do? Reverse opioid overdose, expand the use of Narcan. So we talked about that being a life-saving drug and making sure that government officials like police or people who are first-line medics and first responders from the scene know how to use Narcan and have it available to them to administer if needed. And finally, we come down to any questions. We've gone through a lot of questions, and I know we are over time, well over time, so I'm going to stay to discuss any questions afterward. But I do want to close and thank you all so, so much for paying attention and engaging and being my audience today. I only learned a lot from you guys. I appreciate the questions, but it helps significantly. Thank you, guys. You're welcome to leave. You're welcome to stay. I'm here. You can come up and ask questions as well. Thank you.